Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. I'm your host, Salma Abdallah. Today, we're exploring what it means to lead, teach, and practice public health from a non-Western perspective. Public health, as a field, often represents itself as global, yet much of its knowledge, language, and priorities have historically been shaped by Western institutions. So, what happens when we shift the center of gravity? What happens when we start from Dhaka instead of Geneva or Nairobi instead of New York? My guest today has been doing exactly that. Dr. Sabina Rashid is professor at the School of Public Health at BRAC University in Bangladesh, where she was also dean between the years of 2013 and 2023. Professor Rashid has spent decades working at the intersection of anthropology and health, with a particular focus on how poverty, gender, and health intersect in the life of marginalized communities. Her writing represents years of deep anthropological engagement with communities whose voices are often absent from global health conversations. Sabina, welcome to the podcast.
Hi, thank you for inviting me, Salma. I'm quite excited to be part of this podcast series because I do think it's so important to bring in different sort of evidence and experiences and perspectives. 'Cause context matter, as you know.
No, I fully agree. And I think this tees me up very well for my first question, which is about BRAC. It would be great to tell us a bit about the university, the history of university, how it started, but also what made you interested in creating a school that has a different understanding of public health teaching and practice that just differs from our existing paradigm.
Okay, you're asking me to say a lot in a little nutshell, but I'm going to try.
That's why.
Well, BRAC
Yeah.
University was founded by the founder of BRAC. It's one of the largest Southern-led NGOs in the world, late Sir Fazli Hassan Abid. And it was his dream. He actually gave up his private sector job during the Liberation War to set up camps for people who were affected by the war. And this led to, can we have an approach that's very community based around food, health, microfinance, training. So it was basically education and health with microfinance to help these families who are really, really affected by not only poverty, but by the war. This eventually evolved into BRAC, but then he set up the BRAC University in like 2001. And
Yeah.
I joined in 2004. So I've been there for
Yeah.
21 years, do a lot of multi-country consortium partnerships. So BRAC School of Public Health was set up in 2004. We have an international master public health program. We have a lot of research. And while it's stressful to look for grants, at the same time, it really allowed us to build our own kind of teams and work with partners around the world, but also it helped us kind of generate evidence from the global south. If we use terms like global south, we're kind of in the forefront of doing our own research. Then I think because I'm a social scientist, I'm a medical anthropologist, interested in health disparities, I brought that element into the school. I said, we cannot do public health and just do numbers. But I also felt it was critical to understand the how and why of health. Okay, 50% of the population are, have antimicrobial resistance or are suffering from a certain virus. Why are they? How do we understand better what communities are doing? How do we better understand communities? And I think that brought in the element of developing a more social science component to public health. So some of it was I was driven by my own interests. Secondly, I actually felt as I got older that this is really critical for public health. It's only now we talk a lot about multidisciplinary, interdisciplinary, bringing in anthropologists, bringing in historians. But in 2004, it was very much about bio, epi, statistics, surveys. I mean, there were some people looking at, qualitative. So some of that has been my own journey, but I think it's increasingly now in the world we live in, post-COVID or even pre-COVID. I mean, the world collapsed because of COVID, but I would argue we've had poverty and health and its interconnectedness for a long time. COVID was just magnified the level of the problem. And I think it just made everyone look at it a little bit more, comprehensively and realize we have a huge problem. Yeah.
I think I fully agree. So first of all, the part about being in your 20s, maybe because I'm in my 30s now, really resonates with me because I have my students who come in and I always talk about in your 20s. Yes, you're very certain about a lot of things, but it's also time to explore and actually realize what you want to do. So that resonates with me. But I agree with you. It's interesting. So I studied medicine in Sudan and practiced in Sudan. And then I was always interested in any factor that is not healthcare. I've seen it in healthcare settings that affects health outcomes. And I know everyone who's studying now public health, they hear social science, they hear interdisciplinarity, and they think, oh, this must be foundational to the field. That was not the case 20 years ago. 20 years ago, it was very, I even dare to say, it's just not revolutionary in a sense that we're trying to dismantle anything, but it was more of just like, this is uncommon for public health to focus on social science issues. So definitely agree with that.
I felt when I first joined, it was almost like, yes, you're there. And even when I took over as dean, the founder, Fazli Hassan Abid, basically said, Sabina, I don't want a doctor to run the School of Public Health. I want you. You're social science. I feel public health needs to expand. Because he'd
Yeah.
set up BRAC and he knew that you need a holistic approach. And then they would add a few quotes, and it was almost like, here's a few quotes to supplement key data. And I
Yeah.
really wanted to upend this hierarchy of evidence. Who decides what evidence counts? And now
Yeah.
social science, much more in the West, we're still catching up a lot more in our part of the world. We have to have anthropology and sociology and even history to come in to understand the nature of disease, the history of disease, but also how do we find, it's not about let's just get stuck in abstract. A lot of the work I do, we inform policy, programs, government. So it's not like, oh, we sit in theories and talk about problems. Yes, we say it's messy, it's complicated, but this is also how we need to approach it. Can we not have a simplistic solution and blame the poor for having disease?
Yeah. Oh, I agree. So you came in, and that was a different vision. And as you said, like again, like, in Sudan, it would be very hard to convince anyone in the School of Medicine that we need to think about different types of evidence to inform our practice. So, what were the biggest challenges that you, or the changes you thought I need to make as a dean as soon as you started as a dean at BRAC School of Public Health?
So when I took on the deanship, I think one thing when you work in a new school that's not so entrenched like Harvard or Boston, which is 300 years old, but the bureaucracy also matches some of those changes. I think when I was dean, I was like, I'm going to bring in and set up social science research. I'm going to apply for grants that look at public health from multidisciplinary perspectives. And I also met like-minded colleagues in universities and institutions in the UK. And I said, can we work together? And some of it was like, we won some grants, long-term grants. I also was really interested in rights, human rights perspectives, but from a contextual perspective. So when we talk about women, can we not have gender very much a north-centric lens of all women are oppressed and all men are oppressors? I said, can we talk about class, race, caste, religion, privilege, and power?
Yeah.
So, the rights-based perspective looked at poverty of men and women. I'm not saying
Yeah.
women are not disproportionately affected. In fact, even more so now with the backlash on gender rights. But on the whole, I think when you're working in a new institution, it was set up in 2004, there was a lot more leeway. I had a lot more support from my colleagues. I also went about recruiting colleagues who are interested in social science and health.
Mm.
Because we already had the epi group and the statistician group and the health economics groups. So I just felt like I needed to build that aspect. And then how do we work together? How do we make it much more interesting? The public health research we do, the teaching we do. In fact, I started working with others to rework our curricula. Now we're like 30 as a team just for this center, and 2/3 are social sciences, right? So it's just, and that was like, what, 10, 11 years ago. But I'm just
Yeah.
saying about keeping at it. Of course, there's challenges, but I would go and present at government, and they'd be like, thank you very much. That was very interesting. But what's your percentage? How many national level representative samples? So I learned early on that, of course, I'm going to do national level surveys, but I'm going to bring in rich ethnographies. So it was about
Yeah.
playing the game, but also bringing in the importance of sharing narratives and stories. Because I think
Yeah.
you can't just be like, well, that's it. I'm not going to do surveys and I'm just going to talk about the narratives. Because I think to talk to government and policy and donors, you have to tell, it's like telling a whole story, and part of the whole story is bringing in those elements. So it's not like I would say, okay, no more surveys. But like when we won this big grant, I remember pre-COVID, we did a national level representative survey on men's SRHR. And then we did
Yeah.
ethnographies in about six sites of the country, six districts of the country, and we combined it and said, this is what the ethnographies are showing us. This is what the quant, and this is how the ethnographies are answering some of these why and how and the differences between age groups and caste and class. In our case, it's religion and age. It's about so being passionate. Like I had to be smart about if I'm going to talk to government, I need to tell them more, and it's also important for their programs,
Yeah.
for their policies. If that makes sense, you know.
No, it does. And just quickly, so for those who don't know the term, it's SRHR is sexual reproductive
Sorry.
health
Yeah, yeah.
for men. I know there are people here who also listen who are not necessarily also public health people, but I fully agree. And I think so. It's interesting. I don't know if the history of BRAC, and I think you said this, like the history of BRAC also shaped what you did at BRAC University School of Public Health, because I don't know if you can tell us a bit about ORS. Is the story I always tell my students. So oral rehydration solution that was started by Barack. So if you can tell us a bit about that history, because I do think also he shapes, from at least from my reading of the university, what the university ultimately ended up focusing on. I wonder if it made it easier for you as an environment to work there.
I think that's a really good point, Salma. There's a taken for grantedness of my environment, but the founder of BRAC was very much community based. So public health, which I talk about, is not about disease. He'd say,
Yeah.
let's look at where people live. Can we help them with education, with some finance so they can have some poultry or do some farming? Can we provide subsidized healthcare and make sure the kids who've dropped out go to school? So I wanted to give that picture because ORS, and I heard it from, I was privileged to hear it from two people like Richard Cash, who passed away. He was at Harvard, and Abid Bhai. We called him Abid Bhai, Fazle Hassan Abid, the founder of BRAC. So when ORS was rolled out, we had huge numbers of diarrheal deaths, okay? And we wanted to address it. And this is like in the 80s. People are, oh, the poor, they're not literate, or how, we always think top down. Abid Bhai was like, I'm going to go to the communities. We need to come up with a solution that women can manage. And they came up with this solution of using a woman's palm to calculate the amount of molasses amount. It's be gur lobon water. So it was salt, water, and a certain ingredient, right? And they said, can we figure it out in the hand? Because we don't want to say 3/4 of an inch, this and that. And women picked it up very quickly. Then Abid Bhai, I remember telling me, I realized soon that the women were not responding, even though like we had health workers in the field, they were talking to them in discussions. And then we realized we weren't speaking to the men. So again, they started the field work and started talking to both the women and men because it's a family. Men and women, both parents care about their children. So then they started talking to the men and women about this solution. They said women are at home a lot. This was in the 80s. Men were going out. This is what we're trying to do. The men were like, great. So Abid Bhai was like, when we talk about communities, we want to talk to both the women and men. And then they went to talk to the local religious leaders, the local stakeholders, the local leaders who became the influencers. And it took off. And diarrheal deaths came down. And another thing about moving beyond the disease approach, like, oh, you know, you have diabetes, start eating this. It's like you live in a world where you don't have options to eat. I mean, if you look at America, right? What do poor people have? They're food vouchers for processed food that they get out of tin cans, which is high in sodium, really bad for your health. And then we blame them for being obese. There's no parks. I remember living in New York, sorry, just very quickly, for 6 months. I was at Columbia as a Fulbright, and I got lost and I went in an area that was very, I would say, not well maintained. It was poorer part of New York. And I suddenly noticed there was no parks, no trees, lots of broken cars. Starbucks had the toilets locked. The streets were just, everything about it was like a parallel world. And living in Bangladesh, it's the same thing. You work in informal slum settlements. It's like being in a parallel world. You go down Dhaka city and you have skyscrapers. And then you go off to a periphery area and people don't have basic water sanitation. Food is
Yeah.
expensive. Yeah.
Yeah.
Sorry, I'm
Yeah.
like going off on
No,
tangents, but like, a lot of this I just feel is so important for students to
yeah.
understand and people in public health. Like it's everyday lives that are affected,
I fully agree, and it's so. This is so interesting to me. And to be honest, coming here to the U.S. in Boston, but especially in St. Louis, I see that delineation so much clearer. About like in St. Louis here, there's something called the Delmar Divide, whereas like Delmar Ave is one street. I live in one area that is one of the better off areas in St. Louis. If you just cross that street, it changes drastically. It's because of
Yeah.
laws, of course, in the U.S., where like they divided the city based on that during the red line laws. But it's so fascinating to see like exactly what I said. People live in a parallel world. If I went there for I was trying to work through the tornado. They had a tornado. I was trying to help, but if it wasn't for that, I would have had gone to that area. Like I could have just lived my entire life in St.
Yeah.
Louis, in
Yeah.
just in the nice area that I live in, which is I think exactly what you're talking about. It's the parallel areas, and if you don't go and talk to people in the communities about what they need and what they're working on and what they have that they can build on, it is much harder to actually
I,
intervene.
the point is with public health is we blame the individual, right? And
Yeah,
then current rhetoric does it even more. But public health itself, when it focuses on disease, take medicine, eat, diet, lifestyle. I don't think I can use the word lifestyle for many people who live in America, in poorer countries all around the world. Disparities not just between countries and developed and developing countries. Disparities exist within countries. And
yeah,
when we say lifestyle, we're assuming they have choices and options. But I mean, in Bangladesh, or even if you look at Nairobi, I've worked in Nairobi. But if you look at even in New York, I saw so many homeless people. Oh, they're just druggies. We blame people for their lives. We don't look at structural and social determinants, unfair policies, taxes, unjust sort of laws. We try to demonize and
yeah,
homogenize the poor without looking in as like they're human beings. And how do we need to change the narrative of public health? How do we need to
yeah.
change and have a paradigm shift of how we understand health of human beings? And what is our responsibility and accountability? And Salma, another point that when you're talking about when there was a disaster and you had to go, you have to talk to communities. They cannot be objects that we look at, the
Yeah.
other, that we look down at and feel pity for. So there's two problems. We demonize or we feel pity for. So it's a holier than thou. But these are communities that we need to learn from, work with, understand. They're partners. And we have to understand and have conversations about their lives
Yeah.
and their needs and priorities. Right?
And I think this is very relevant. I think you've written about this, and I've thought about this. I also written about this, especially during COVID. Is really like a foundational question of public health. Exactly what you said. Who designs interventions and for whom? I read your article about COVID-19, especially in the informal settlements or slums in Dhaka, where we had shelter in place laws, which was similar to the type of laws we had in Sudan.
Mm.
And it seems to me, and at least maybe I misread your article, it's similar issue to what we had in Sudan. Just like it was very hard to tell someone. I grew up in a neighborhood that was not well off in Sudan, in Khartoum. It was very hard to tell people to shelter in place in a house that has 12 people in 3 rooms. Like that doesn't help. And I remember talking to my mother when I was telling her, you need to stay inside of the house.
Mm-hmm.
You shouldn't go anywhere,
Mm-hmm.
and or say that to the family, and they would say, it's great that you care about this whatever virus that you're talking about, but we had a shortage of bread, and we need to send someone from the house. They have to stand in line for like 4 hours to get bread. This is the priority for us now. So as much as we would like to listen to you telling us we need to stay at home with a crowded house, we have other priorities.
In Bangladesh, when we had the global lockdown, right?
Yeah,
It's
yeah,
a privileged view of what affects your life. It's a privileged view of hierarchy of risks. So I write
yeah,
in my book, Poverty, Gender and Health, Children of Crows in
yeah,
Bangladesh. I write about this because I follow them for 2 years, families from 20 years ago
yeah,
and COVID and post-COVID. And I said, fundamentally, you may have phones and you may be more mobile, but endemic poverty and impoverishment has not changed. So you know what the women were saying to me, young girls, they were like, you think I'm scared of COVID? Of course I'm worried about COVID. I'm more scared of having no food. How am I going to feed my children? Who's going to feed, the elders? How am I going to manage? And they desperately tried to be inventive to get out of lockdown. What did they get?
yeah.
Fined and penalized by police and the law. And this whole notion of COVID is a disease going to kill me is a luxury you and me, Salma, can do sitting in you in Boston and me sitting in Dhaka. I worked remotely for the first 4 months, got my salary. The average person, with 80% are informal workers, which means they rely on like labor. Could be daily wage labor, it could be domestic work, and that's how they survive. And most of them lost their jobs. How are they meant to eat? And our government did roll out some stipends, but it wasn't prolonged, it wasn't sustained. And then you have politics. We don't talk enough about politics and health. You also have in every micro neighborhood powerful leaders. They pick and choose who gets relief. We had long lines. We shut it down. We also had them saying, if you report your symptoms, the police will take you to the hospital. The police are people they're very scared of. Police are constantly picking them up. And so there's such a mismatch. And in our country, there was a clinical task force, like in many countries. And I write about this, but I wrote with other colleagues that we need to expand the notion of risk. We need to expand the notion of health. Because if we're talking about context matter, if we're talking about global health, 80% of global health problems are in developing countries. Why do we still have a very disease oriented approach to global health? Why are we dismissing most communities' experiences of health where they say, I don't have water. Water comes for 20 minutes. My job, I just lost my job. My mother just got injured. My food, the prices have gone up. So we're living on water, chilies, and potatoes for about a week. Why do we dismiss that in health? Because I was just thinking, Salma, for me, if I come home and I've been evicted from my home, imagine I come home and I have nothing. I've lost my job and I need to eat. Why would that not affect my health? Because I'll have less nutrition. Forget the well-being. Less nutrition. I can't afford stuff. I'm on the streets. Like, why is that? Why have we used health in such a siloed way? Sandra writes about it. I write about it. A lot of people write about it. We still, and I think some of it's about we don't want messiness. We don't want complexities. We want, hey, we'll deal with this. We'll deal with disease and then set up more biotechnology to deal with it. I'm not saying we don't need technology, but I'm saying we need to address some of the underlying root causes of why people are sick, where they live, and why they're falling sicker. Why are they falling ill all the time? And it's not about they don't understand. Most people I've met in communities are smart, capable, resourceful, because they have to manage with a lot less than you and I.
And I think so. This is interesting to me because, as you said, like increasingly we're saying public health shouldn't be siloed; it should be interdisciplinarity, and we should include social science. But at least I think in Sudan, but also I think from what you're saying in Bangladesh, when they created the clinical task force, when it's time to act, all of these buzzwords that we use about social science and interdisciplinarity suddenly disappears to saying like, who are the 5 doctors we want to have in the room? And instead of talking exactly, I said like, should we have economists there? Should we have sociologists? We have
So
anthropologists.
we have economists, but
Yeah.
sorry, Salma, to interrupt you, but like we have economists and we have doctors, but we don't have people from different disciplines coming together. We became part of a South Asia group that was funded by IDRC to look at social science and COVID. And many governments started changing their policies by 2021, where they realized the lockdown had created more hunger, more unemployment, more insecurity. I think
More gender-based violence.
of course, gender-based violence. People like sex workers were on the streets. You had poor men I knew girls who were maids who were offered, like if you have sex with us, we'll give you a lot of money. And they were like, no, I can't. But they started begging on the streets to survive. And I think the reality is that this is an entangled web of control and power. I mean, I think disciplines are territorial. Funding have a certain kind of language of a magic bullet. Vaccines are going to do it all. Vaccines are important, but it's not going to do it all. I can get a vaccine, but if I live in an extremely shitty place where waste is around me, where there's no roof, I mean, water's dripping. I get diarrhea every other day. I can't afford to eat. So I'm saying vaccines need to come along with other components of health, which is housing, water, sanitation, basic job, basic food. But I think it's power, it's politics, it's privilege. I think we continue to look at traditional public health And that seems to be the way forward. I'm not sure why, as you pointed out, whenever there's a crisis, we go back to very conventional public health, very conventional biomedicine. And I think we need to start challenging this. And I think academics need to start working together, but it's beyond
Mm,
academics. It's about policymakers being pushed within to
yeah,
understand. We know what the
yeah.
issues are in public health.
And so I want to pick up on something that you said. Well, you said power, but maybe going even on a more local level. And this is a question I ask everyone. You said local leaders have power, right? They get to decide. Like, so sometimes when we say communities, they are included in the communities we think about. But then, at least here, it seems to me that the conversation about communities disregards some of the power dynamics within communities.
Yeah,
So in Sudan, like I work on female genital mutilation, and I came here, and I'll talk to people and they say we just need to leave it to communities, and then communities are going to solve the problem without really recognizing the power dynamics also within communities. Like, I don't know how to explain to people, if we just had let a specific community with just the leaders decide what is needed, I
mm,
don't think FGM would never have ever become a priority there. So we need to think about also about those power dynamics within a community and how do
absolutely.
we tackle those.
Absolutely.
I don't know your thoughts. Yeah.
No, so a lot of the work I've done, I use, not to use big words like intersectionality, but I like to work with people who are diverse, okay? Because a
Yeah.
community, just like you and me, we're not homogenous. I don't represent every Bangladeshi woman,
Yeah.
or group or category or age or background. Neither do you for
Yeah.
Sudan, right? So when I work in urban informal settlements with communities, that doesn't mean just male leaders. I talk to female headed households. I
Yeah.
talk to elderly people. We talk to people with disabilities. We talk to adolescent girls because I think it's very important in any kind of leadership. There's always an absence of voices, right?
Mm.
And I think when we look at public health also, a lot of our research has found, particularly in the Rohingya camps, but in urban slums, when it came during COVID or a crisis, it's those households without any male guardians that suffered more. It was those households where they were elderly, couldn't actually line up for 3 hours to get their food rations. Those adolescent girls who were married early didn't have much of a say because it was the mother in law or father in law deciding. And I think it's
Yeah.
very important. And then leaders themselves, this is the paradox, right? So you have these leaders who are powerful because they have political ties with others beyond the slum, police,
Yeah.
and other politicians. At the same time, these leaders then become, exploit them, but also become their protectors, right? Because the structural system and the lack of governance has created these systems to flourish. At the same
Yeah.
time, you've created these systems where you have leaders who then control their own populations, right? Then you have larger level leaders and politicians who make sure that everyone else is kind of affected because, I mean, at the end of the day, I feel when I work in slums, even when we talk about power and privilege and politics, I don't find it's a win win. I feel they're a product of the structural systems and the lack of governance and corruption in many of our countries in developed and in
Yeah.
developing countries, what I see, right? And what you happen is we've created these power inequities within slums. I agree, which is very important to understand health and health experiences and lived experiences, and particularly gender and vulnerabilities,
Yeah.
but by having a much more micro understanding. And I think sometimes RCTs homogenize groups and
Mm.
qualitative and ethnographies and social sciences bring out these different diversities and the complexities of even priorities and needs. I'll give you an
Yeah.
example. Young girls, when they're talking about making latrines, they were really worried about space at the bottom and they wanted more privacy and they wanted some space that, allowed them to change their, either
Yeah.
their menstrual cloth or their sanitary napkins. And if I just spoke to a bunch of guys, they'd be like, can we just fix the door? Right? So, I mean, it's very important to understand that, and then whose voice speaks for whom. And I always find with even as an anthropologist doing field work, am I representing enough of the diversity of voices? Have I
Mm.
shared some of this feedback and validated some of the, and am I willing to adapt and refine and change the course of what I'm doing if I'm being
Yeah.
ethical? As opposed to this is convenient, we've already figured this out. How do we make this work? In fact, one of our
Yeah.
projects, Arise, really did that. We built
Yes.
water points in the slums where we found that certain people just didn't have access to water. They had to walk, particularly women, but some of the men walk like a good 20 minutes to get water. So we then built water points, but we had to work with the local leaders and incentivize them by saying, well, you're the leader, and work with them to allow for water points to be set up for the more marginalized communities who don't have access, right? Same thing with
Yeah.
latrines. So it's about working and being aware of these nuances that you point out, Salma. I think it's very important. Yeah.
So, two threads here I actually want to pull on. I think I'll get back to the gender one because I actually really like that you frame that gender sometimes also is like men are affected a lot by how we think about gender in
Yeah.
a society, which I like that that's a thread throughout. But I'll come back to it later. I really want to push down more about your experiences and then ethnographers because I think your book, which I didn't get to finish all of it. I'm actually reading it right
Oh,
now. I
thank
was reading it
you.
for in preparation
Please
for
share
this.
your thoughts,
But
though. I'd like to get feedback
yeah.
because I'm starting a second one, but looking at young
Oh,
women who are
that's
going to
great.
college who live in slums to
Oh,
understand
wow.
their experiences. Yes, I'd
Yeah.
love to get your feedback.
Yeah, happy to send it to you. But I think yeah, so it's I think you mentioned earlier. It's called Poverty, Gender, and Health in the Slums of Bangladesh, Children of Crows. In case people are interested in buying it, and we'll put a link also in the notes. Uh, I, as someone who was trained in clinical medicine and then in epidemiology, I would love to hear first why ethnography is that's what you picked, the field that you picked.
Yeah.
And also, what does it mean to immerse yourself? I think you mentioned like for 2 years in a project, and how do you usually think about that method as you're writing a book?
Some of it is just okay. My training in medical anthropology, and also you end up doing ethnographies. You end up spending time with communities, immersing oneself. I mean, if I simplify it for even students or people, you don't have to spend 2 years. I mean, I had the luxury of doing another project for 2 years, but even can we spend 3 months or 6 months? Because when people start to trust you, residents wherever they live, they open up and start sharing. It's beyond the standard, oh, nutrition, standard politics, standard, like I have this disease, I'm managing, because you start having conversations with people and and it's about how you approach it. So ethnography really is about narratives and trying to learn about individuals. I call them, some of them, my friends because they became my friends over a long period of time. Of course, the power relations are different, but at the end of the day, the power relations also shift. I relied on them, they started relying on me. But immersion is really spending trying to understand their everyday lives. My first training was when I was doing my PhD, which was a long time ago. I had a set question around reproductive tract infections. I wanted to understand vaginal discharge and terminologies around that. And I kept going to the slum. This slum I picked, it's called Fulbari slum. And it's in the
Hmm.
book because I talk about present and past. And I kept asking these women, tell me about, did you go to this clinic and what was your symptoms? And as I was spending time with them, they were like, my husband just lost his job. I'm a tenant. Oh, I have to go now because I need to get water. Water's going to come for 20 minutes. And I see them take these buckets, rush back and sit down. And the child would cry and say, what's for lunch? And she'd be like, be quiet. I'm waiting for your father to come home. He'd come home. He'd give her one egg and they'd have a bit of rice. She'd start cooking it. Then they start arguing because she'd be like, well, I haven't eaten properly. And he'd be like, do you think, it's easy for
Yeah.
me? I've been also struggling and, they've shut off these roads and the police are finding us. And then I'd see all of this and I'd get really frustrated. And I'd be like, yes, I studied anthropology, but like I also want to understand a more medical anthropology of like culture of language. And it was more, and then I shifted to actually critical medical anthropology, which was,
Hmm.
and I'll explain why, because I'll be like, I remember writing to my supervisor going, I'm not getting enough on their health seeking behavior and all of that. I mean, I had larger questions, but I thought, let me start with health seeking and then go into their lives and experiences. And then it struck me one day because I was looking through my notes and I thought, they're telling me about health. Sabina,
Hmm.
you're such an idiot. She's telling me, I don't know if my husband's got a job. I've got one egg to eat. I haven't eaten in 2 days. I have to rush off to get water. All of this is
Yeah.
impacting. And then she started talking about, I feel weak all the time. And then I have discharge, and I don't know if the discharge comes from an infection. And then I looked at their rooms. There's one bed sheet. There's barely a fan. There's a little room with no ventilation. And I thought, discharge is just one symptom of a larger problem, public health. And I think that's when I realized I need to immerse and understand their everyday lives and spend time with them. And it kind of changed my life. It changed the way I understood public health, but anthropology, but also critical medical anthropology, but also communities. And I just realized I cannot do public health the way it's being done. And I cannot do medical anthropology the way it's done. I'm not interested in the language and culture of discharge. I'm really looking at gross health disparities, stark health disparities. And what does health mean? And
Yeah.
that actually changed from my PhD onwards. I started bit
Yeah.
by bit trying to understand more broadly what is health.
When you meet people who say, and I think you probably met a few of them who say, well, ethnographic work or anthropology is not rigorous enough as what we do in epi. What do you say back?
I mean, people don't say that because they're probably a bit scared, but if they do, I would
Yeah.
say
Yeah.
when you spend 10 months, 12 months trying to understand, because the depth and the detail of the ethnographies, and there are anthropologists in public health writing about public health. Some of them, there's a lot of famous people. So I don't think people say it's not rigorous enough. I think they would not understand it. They're like, well, you looked at 10 case studies. How is this like representative? And I'm like, well, 80% of informal workers have these lives. I've got, 60, 70 case studies. I'm just sharing three
Yeah.
case studies. And when you have that level of detail, I've not had anyone say it's not rigorous enough. I've had people say qualitative, well, very interesting, 10 women said this. And I understand qualitative, like quantitative, if it doesn't have methodological rigor, any of these disciplines,
Yeah.
be it quant or qual, it'll show through in the quality of the data, right? It'll be very
Yeah.
generic. The deeper the depth, and ethnographies tend to be very, very detailed. And then you've got literature and enough data. If I say, there was a queue of, in my book, I talk about 6 women. There was a queue of like these 6 women wait for 3 hours. There's enough 20 newspaper articles that talked about during COVID that thousands of people were lining up for 3 to 4 hours just for food relief, right? So it's not something that people can get away with. I think rather than get into ethnographies are known for their methodological, you know, um,
Yeah.
excellence in its field. What I really like is being brought into public health. I think one of the criticisms around qualitative, and I would say the same for quant, depends on the variables and the levels of analysis. If qualitative is used just for a few quotes and it's not representative, it doesn't show diversity, it doesn't show nuances, then you can challenge the rigor. And I have worked with colleagues who have given me qualitative data, and I've said, excuse me, you've just made some very generic statements, and this can be misused, and I'm not clear about
Yeah.
your methods, and we need to strengthen it, right? Same with quantitative. You jump to certain kind of conclusions using certain variables. And if I work with colleagues who are epidemiologists and statisticians who will be like, no, I think we need much more analysis around intersectionality in this survey of younger men, older men, Muslim, Hindus, to understand risk behaviors. So I think that criticism can be looked at by any discipline if you don't actually do the methodological rigor that's required. I
Yeah.
mean, I
Yeah.
think
Yeah.
you can get away with a lot of crap anywhere.
Yeah. Yeah.
You can be
Yeah.
like very careful and just say,
Yeah.
this is how. And also for most people who are doing public health, I mean, for us, we have to publish, we have to present, we have to, and more than that, we're presenting to government. You've got people in government who are in research. They ask very hard questions about which district, what, and how, and what are you recommending. So you can't
Yeah.
really, just say, oh, okay, it's an ethnography, so therefore, lots of
Yeah.
story, which people liked.
Yeah. Yeah.
Yeah, I don't know if that's a good enough answer, but I just feel like rigor itself needs to be
Yeah.
challenged. And another point I wanted to say, and I've written about this in Lancet, sorry, is that
Mm.
one of the problems in this model of the North we've
Yeah.
inherited here is the individual research expert. That's really
Yeah.
flawed. You need to have communities and practitioners in your research team. There is no individual expert. The data you collect is actually enriched by communities and practitioners, and you need them as part of your research team. Along with multidisciplinary, it's not just adding a bunch of researchers together from different disciplines. You need to have
Yeah.
communities part of your research. if it's not too sensitive, I'm not looking at sexuality or SRH, but you need communities and you need practitioners because practitioners, communities know their context best. You know your home best. You know your lifestyle best. This individual health expert is actually hugely flawed in the North, and we've cut and pasted it because it works for us. I'm an expert. I'm the professor of poverty and health and, blah, blah, and I'm the anthropologist. But really, I'm not. I'm learning from communities. There are teachers, right? We're trying to understand and learn. Yes, there's harmful practice. There's a lot of stuff that we can learn from them. And there's practitioners who've been implementing programs for years.
I think when we say rigor, everything can be rigorous or not rigorous. We say you just have to be very clear what we mean about rigor. And I actually, it's interesting. I think I read the article in the Lancet. I've been preparing for this for a few weeks. So I read a lot of your articles.
Group questions. Thank you. Probably more than most people, so I appreciate it, Salma.
No, I learned a lot, and I think I agree, especially when it comes to public health. And that's the interesting part for me. We pay lip service to all of this. Like it's very hard for you to go to a place right now in public health who doesn't say we need to, of course, think about different perspectives and think about practitioners and think about a sociologist being here or someone else. But it's always interesting to me that we just somehow always then revert back in practice to something very different from what we preach, which is that's a disconnect. I think I'm trying to understand.
It's about power, and I think it's about who's in charge, and I think it's about even there was a criticism that a lot of papers are written by, I have a different take on decolonialism. Yeah, there is a lot of the colonial legacy. There is a lot of the overtly differential, but I also think it's not so simple. I think it's about elites, it's about privilege, it's about how I use my privilege as a dean, educated, and what I do with that in my own country as well. We talk about parachute researchers from the West. We don't talk about domestic helicopter research, which is I fly in and out of my own country in one field and I write about it. But I think a lot of it's about power and privilege, and we have to shake it up a little bit. People have to give a little bit, give up their territory, give up the silos, and say, okay, how do we make this work better if our actual goal is improving health of the disadvantaged populations? Right?
So that's interesting. Maybe it's a different conversation for decolonization because I feel the same. It's so funny to me. It's so interesting that we talk about power differentials between countries. I am fascinated, and maybe because I grew up in a low-income area in Sudan, and then I got very lucky, and I think now in a much better and a privileged position.
I don't know if you're lucky. I think you worked hard and you achieved what you did. It's not about luck. Yes, there is good opportunities, but some people don't actually get this far. You did well, and you worked hard for it, Salma. I want you to remind that because I think we often kind of dismiss it as luck. No, I worked really hard when I was dean, and now I'm working really hard on my research, right? And we need good people who support us along the way, and mentors and other colleagues.
I appreciate that. Thank you.
No.
But I think it's interesting because within countries, sometimes I have it feels like it's a weird conversation. There are some people I know in my country who've never been to neighborhoods and who would lead the Ministry of Health in Sudan, right? And would never been in a neighborhood like mine. And it was always mind baffling to me to say this person has more authority than someone who lived in Delmar area that I was just talking about in St. Louis, who knows more about poverty, I think, and who might have a comparable life experience to my mother than this person who leads the Ministry of Health in Sudan.
Agree.
So I really appreciate that perspective.
I don't think we talk about the I think it becomes very convenient about us versus them. But if you look at abortion, if you look at certain rights for sexual minorities, this was across borders, across countries, movements that came together. Then to reduce it to you, us, versus, that doesn't take away from, yes, there was colonial legacies, that doesn't take away from, but how are we reproducing certain things? How are we just, I think scapegoating and making one group all bad and us sort of like these victims is not helpful, because I think if you look at public health, even in our lives of development, I've had fantastic partners who are extremely supportive. I work with people who've worked in areas, as you were saying, with a lot of poverty, have better ideas than some of the people where I live and people I meet that have never, ever stepped into a informal settlement. I met
Yeah,
Bangladeshi and even kids, because we have kids from all over the world in our international MPH who've never been to a poorer neighborhood. Like they live in a bubble. So, I mean, I think we need to have those discussions. So otherwise we end up losing a lot in public health. It's sort of like you
I agree.
versus us versus, and then leave it at that. How's that helpful? I
Yeah,
don't know.
I fully agree. This is actually making me think. Hopefully, I'll bring you back for a conversation about decolonization because I agree with you. I really think there's so much nuance that needs to be added to that conversation. It seems like we stopped at a certain place and then we never move forward
Yeah.
or made the conversation more complex. But just quickly, I want
Yeah.
to go back to the thread that you said about gender because I thought that was interesting. I see this here in the U.S.
Yeah.
I listen to some of the what you call like we have the gender backlash,
Yeah.
the manosphere, what they call them here, manosphere podcasts, and of course, a lot of it is over the top. It's just very hostile against
Mm,
women and
mm,
sexual minorities.
mm.
But at the same time, I think that sometimes it feels to me like in public health, yes, women, of course, burn the brunt of a lot of the difficulties we have that we need to address in public health. But it seems to me sometimes the conversation about gender mostly just focuses on women, and sometimes we forget what you said. Like we don't include class, we don't include any other issues that people need to think about. Like during COVID, I was part of writing up about the impact of COVID, and we usually always all the time think about gender-based violence, which it did happen. It increased during COVID. No one can disagree with that.
Yeah.
But it was rare that when I'm writing a gender section, that we also write about how it was mostly men who were dying from COVID because they were exposed more. And I don't know how in public health we can hold two things at my. It's just yes, women are really vastly affected by all the inequities we address, but at the same time, men in certain situations, because of how we think about gender, are actually severely affected. Especially like here in the U.S., you have
Gun violence.
younger,
You've gun
exactly
violence. You've got
suicide.
black men being locked up disproportionately in
Yeah,
jail.
yeah, yeah.
And then they're
You have
blamed.
suicide. Yeah, yeah, suicide among teenagers. Like it's the numbers were fascinating to me when I read them. Like it was really shocking. Like most of the teenage girl, like the majority of suicide ideation is among teenage girls. But in the U.S., the vast majority of teenage suicide is actually, I think, up to 80% among teenage boys. And that to me is like we don't necessarily talk about that. So yeah, I don't know if you have
I
thoughts on like how
actually
do we address gender in nuance? Yeah, yeah,
I think we need to really push back. Like, why do we
yeah,
have this one linear model from the
yeah,
70s or 80s? I'm a feminist, I'm all for feminism, but like a very standard definition of gender for the whole world.
yeah,
One. Two is in many countries, in your country, Sudan, Bangladesh, Nairobi, I've worked, Nepal, because we are partners, multi country. For the very
yeah,
poor, in some ways, we're crippling women as well, you know?
yeah,
Because we're seeing men and women sort of individuals who are rubbing up against each other and in opposition.
yeah,
But a lot of these families are together trying to survive. So in
yeah,
Bangladesh, I'll give you an example. Like, I think we needed to work with women because they were having 7 children. Immunization was low. They were not going to school. So the government set up stipend programs for girls to go to school, immunization, garment factories. But then I feel like we somehow along the way, like in many countries, men were just sort of forgotten.
yeah.
So like men don't have jobs, but women are being hired garment factories because they're cheaper to hire in terms of labor.
Mm,
So, things like that. Or like we talk about family planning and contraceptives, we'd give it to women, microfinance, give it to women. We would take it for their husbands for these loans. So why are we so reluctant in public health? Like we took this North American lens of women equals
yeah,
all women are victims, all men are oppressors. And then in developing countries, it's even worse. All brown men, black men are really horrible.
yeah,
And all brown women and all black women are just miserable. They're such victims.
yeah,
America has its own weird kind of narrative around, blacks. I don't want to
yeah,
go there because I don't know it
yeah.
enough, but I'm just saying
Same.
in developing countries,
Yeah,
if you look at Middle East men, if you look at Arab men, if you look at Asian men, they're either effeminate or they're demons, right? The general language of the problematic. I remember when I was getting married, someone asked me, "What's your husband like?" And I won't mention names. I was traveling, and I said, "He's great." Was he Bangladeshi? I said, "Yeah." Oh, so he gives you freedom. You can work. I'm like, yes. So there are these stereotypes, right? And I think the stereotypes are much more than Afghan man. Everyone must be a Taliban. Oh,
Yeah.
Nepalese, everyone must be a Maoist. Every Muslim man, jihad. We have these ideas. It's also affected, you know, men all over the world. And particularly, we don't want to talk about poverty. We don't want to talk about caste, class, racism, because one, public health in itself is so traditional and conventional. It doesn't want to go there. Two, women have been disproportionately affected, but at some point, poverty means that, men and women are also being affected. Men in my country, in many countries, worry about not being the rice winner, the breadwinner.
Yeah.
They get anxiety. You can't get married if you don't have a job. A lot of them are, then they get into, we talked about domestic violence against women. Huge problem, yes. But there's a lot of gang violence in
Yeah.
informal settlements. We don't talk about that. And I
Yeah.
think some of it is, and I don't even want to, I think it's convenient rhetoric.
Mm.
So we have convenience about blame the poor because they're too stupid and we give them more knowledge, education, and programs. You also
Yeah.
have a lot of very much divide and create, immigrants against immigrants. You create men are a problem, women are this. I think some of it's political, some of it's just state. It's just the mindset, and it's not just related to public health. It's media, it's our kind of socialization, it's the way the othering of, of,
Yeah.
of,
Yeah.
of people from different countries and individuals. And that kind of has seeped into the way we understand our world, what we
Yeah.
value, who we devalue, and how we look at men and women. So, like, I'll be honest. I think my husband and I will go to an immigration counter. He'd be given a harder time than I will in most cases because he's a
Yeah.
brown male compared to me being a
Yeah.
brown female. I
Yeah.
don't know. I mean, I don't know if I'm going off topic, but some of this is much more about the world we inhabit. It's not just public health. It's media,
Yeah.
it's language, it's literature. It's about how we view the stories, not without my daughters. I'm not saying there isn't misogyny or violence or patriarchal systems. It's everywhere in America, in my country, Sudan. But I don't think we can say that's all. And that represents all men. And I think when we do that, particularly in public health, we are denying and invisibilizing a huge percentage of very poor men who are struggling to look after their families, who have diseases, who don't take help, who don't seek care, who don't want to be seen as weak, who are really living very precarious lives. And we need to have those conversations. I think it's back to that whole point of we need social analysis to understand. I mean, why do we view the poor as this group that we always talk about? We've already objectified them. The poor in Sudan, the poor in urban slums. I think we really need to take a step back, even us in our fields, and say, we have kind of homogenized a stereotype.
Yeah.
They're,
And I
they
think that's part of what you're saying. It's like, yeah, none of those is a complete story. Decolonization or colonization is not a complete story.
There's
Patriarchy is
multiple
not a complete
truths.
story.
It's multiple
It's
truths
true.
and it's
Yeah.
far more
Yeah.
complex and it's like complicating the narrative,
Yeah.
you say. Let's
Yeah.
complicate the
Yeah. Yeah.
narrative, but talk about what's going on the ground. And it's messy and it's true and it's real and it's grounded, right?
Yeah, I agree. I agree. So before we end, I wanted to pick your brain very quickly. I think I'm lucky to have you today, so I just want to pick your brain about a few topics that I've been thinking
Sure.
about. But the last one is real about your perspective on like what is global health? What does it really mean today? Just the world we're living in, where it just seems like the world is there's so many tensions happening, rising nationalism. We have. I'm pretty sure this is not going to be the final pandemic threat we have. We have geopolitical tensions. So I don't know how you envision what global health is right now.
So
Does
for
it does
me,
the term even conceal
so
something?
for me,
Yeah.
I just
Yeah.
I work at local health. You work at your local
Okay.
health. We come together and we need to understand and explain the world that we live in. Okay. I
Yeah.
want to say
Yeah.
if we're going to talk about global health, then we need to acknowledge and understand that there isn't some standardized universal definition of health. We
Yeah.
really
Yeah.
need to.
Yeah.
We need a whole kind of not just, reimagine, push back,
Yeah.
interrogate, break down, dismantle what health is.
Yeah.
And it's not
Yeah.
just
Yeah.
disease inside the body. That's one. Two, we need to we need to also break down notions of gender, health, well being, and why context matter. Why is it so important? Two. So, language and power is very important. So, my other point about health and evidence is can we dismantle the knowledge hierarchies that exist, which is epi
Mm.
and bio? can we say now there's enough evidence to say social science, anthropology, and other disciplines are equally and part of and inform health conditions,
Mm,
whether it's global health conditions or local health conditions. So we really need to push
mm,
that. I also think we need to kind of talk about public health in a way that brings in discussions around governance and accountability. Uh, I don't know if that makes sense. I don't think we have enough of those conversations. For me, global health, I want to have conversations around governance. I want to have
yeah,
conversations around accountability. I mean, we're looking at
yeah,
climate change. Bangladesh is, I think, one of the eighth most vulnerable countries in the world. But
yeah,
the cause of climate crisis is not even change. For us, it's a crisis. There's no future climate change. It's happening right now.
yeah,
Then we need to
yeah,
talk about accountability. Who's responsible for the climate crisis? Right? So I think health itself, we need to unpack and say, what does it look like in different contexts? And then when we bring
mm,
that together, how do we then dismantle existing understandings? And it's not just understandings, standardized frameworks, definitions, push back
yeah,
and say, we need to redo health and global
yeah,
health. If we want to make a change, if we really want to help those who are most affected, be it Bangladesh, be it Sudan, be it, New Orleans, be it, I mean, I just think it's very important. And that means having some deep interrogation and reflection and working across not only just academics, but, policymakers, practitioners, funders, funding bodies that still exist,
yeah,
And I still think with all the stuff that's happened with money and resources being pulled back, I see a glass half full. I don't like to see it half empty. I think there's opportunities. We can create new allyships. We can create new
mm,
kinds of ways of working together, but make sure that for me it's very important to keep pushing that the people we work with are human beings. They're not a disease
yeah,
statistic or a number or just a narrative. These are human beings, and
yeah.
we have a certain ethical responsibility in our disciplines to share as much as possible on the complexity of their lives. Yeah.
Yeah. So as we come to close here, I think I really like the glass half full part because part of what we wanted to do with this podcast, and hopefully we'll do more of it in the future, is yes, people when they talk about public health, we talk about all the things that need to be done. We think about disease, we think about like no, but we have all of those issues that still need to be addressed. Like usually the conversation is very there are so many issues that need to be tackled. And I think it is helpful for younger people at least to hear about the progress we've made as well. So I don't know if there's one area that you think
BRAC.
we've made, given all your work that we've done. Yeah,
I mean, I think I live in a country like Bangladesh where we had BRAC. They had developed ORS, which was given door to door. It was just sugar, molasses, and water, and it
yeah,
brought about
yeah,
diarrheal diseases. I live in a country where Grameen, who's now, Eunice, who got the Nobel Prize,
yeah,
microfinance, got five women together and said, you become each other's bank collateral. And we set up
yeah,
microfinance throughout the country. I live in a country where kids who drop out of school have a non formal primary education program that they can go and catch up. I live in a country
yeah,
where it's not perfect, but I also think that it is up to us then to change the conversations, to keep moving
yeah,
forward. And I think we have enough resources and opportunities and enough allyship of people who think the same way to start
yeah,
looking at. I mean, there's so many things that are positive. You've got people who are still going on about climate crisis and there's
yeah,
activism there. You've got people still talking about food insecurity and how do we then align it to like health and make sure that people don't get evicted. You've got people still talking about in your country, I guess Obamacare is still there, or I don't want to get
it
political,
is.
but I just know that
Yeah,
there's some kinds of care and insurance. I'm not into your politics, but I just feel like in your part of the world there's stuff that's still going on. People are pushing back, and I
yeah,
think, but I do think that in health, whether we call it global health or local health, health in itself has to be interrogated and dismantled.
mm,
We cannot keep, and we need to start working outside instead of preaching to the converted. I think we do need to have conversations with people in the private sector, people working in different organizations,
yeah,
bring them together. There's a lot of people who have a lot of interest in health and development, who are committed,
yeah,
who have a vision, and some of them just want to give support. But I think we need to start also uh, looking outside the box,
yeah,
you know,
yeah,
if that helps.
yeah.
I don't know.
Well, It does. What would be your advice for someone who's starting today, like undergrads? I just gave a lecture last week to undergrads who are really thinking about health and what they can do. Yeah.
I think you can do so much. I think, you know, just spend time in a community where you live. Try and understand their lives, their health, their everyday lives, their well-being. For you to just immerse yourself in that community, it could be your neighborhood, it could be an hour away somewhere, will teach you so much. You will be, knowledge is what's important about knowledge is you're always learning. I'm 56.
Yeah.
I'm still every day I go to the field. When I do go to the field, I feel like I've learned something new. I actually think that if you're in public health, you are the future. You are the one who's going to create change. You're the one who I hope listening to me and Salma will say, beyond numbers, I'm interested in statistics. I want to capture stories. I want to spend some time with these communities. I want to understand their everyday lives. And one day, whether I'm a journalist or I'm a writer, or if I go into policy or if I go into government, I will create change. It sounds corny, but I do think you do have an influence in policy and in programs. I mean, some of the biggest changes in Bangladesh has been through our journalists. They will write hard-hitting articles in newspapers, and you've had ministers come and immediately change some of their programs because there's so much criticism. So, I mean, I think you can do a lot, and the only way you can do a lot is through learning, so through knowledge, and through writing, and through your own experiences. I don't think there's any shortcuts to learning.
Yeah.
But if you're passionate, you can. We have so many students coming from other countries to our country, doing internships, learning from us. Oxford University every year sends students, and they love it. It's not that but they love being in a completely different environment and learning about communities in rural areas, women and their lives and livelihoods. And I think there's so many opportunities to learn. And I think I do have hope in the younger generation because I feel like they're the ones who are going to be ones who are going to push back against a lot of the shrinking civic spaces that's happening right now.
Yeah, that we have. I fully agree. So the last question we have is what should people take from this? What is one narrative that needs to be complicated as we think about health? Which I think you alluded to. I think I might know the answer from you right now, but what do you think should be the one narrative they really should think about as they think about what they need to do in public health?
I think every individual we meet is a human being. They want to live a life of dignity, and everyone has the same aspirations, hopes, and dreams. So whether we do research or we work in programs or whether we write, whether we want to learn about them, we need to realize we're working with people who have a lot to share and we have a lot to learn from them. Some humility, some respect, and some empathy would go a long way in improving your own public health career. But also, it's very rewarding if you kind of shift why you're in this and what's your goal. What do you want to do? Why do you want to understand their lives? Is it just to get a publication? Is it just to be a teacher? Is it just to be able to get a degree? Is it because I think it's you get a rich, when you understand much more people's lives, you realize how much you have in common. The color may be different. The socioeconomic status may be different. People may live different lives, but the needs and priorities and aspirations remain the same. And I think if you're in public health, it is critical and ethical to tell the story in a much more in a way that's far more comprehensive, realizing there's multiple truths and you're always leaving some stuff out. I don't know if that's what can be a one-liner. I'm not good with one-liners. Sorry, Salma, but maybe if you can come up with something. But I just
that's perfect.
with human beings, and we there's an ethical, moral responsibility we all come with, whether you're a student or a faculty or and they are partners. They're not objects. They're not objects.
Yeah. No, I think this was great. Thank you so much, Sabina.
Thank you, Salma. Really enjoyed it. I really appreciate it.
This podcast was edited by Zach Leonaris and Catalina Melendez Contreras. It is supported by the School of Public Health and Frick Initiative at Washington University in St. Louis. You can access this and other episodes wherever you get your podcast, or you can watch it on video on YouTube. Thank you for watching.